Dr. Gaurav is there. So we have Dr. Gaurav and Dr. Martin. So Martin, what would your approach be?
These are all interesting cases. You know, we also prefer here to go for native fistula as much as possible. That's why we are opening so much the central venous occlusions and trying to keep them open, because you know the one thing is to cross the lesion then put a stent, but the other is to provide long-term patency as well. So there is also discussion about like how what is the medication you keep the patient on post venous stenting, you know, if either to just keep them on lifelong anticoagulation or combining with antiplatelets. That's one thing. Anyhow, if this is gone, or all native fistula options are gone, then you have to go for some kind of bypass. And as alternative, I can just propose perhaps to use the hero graft. I'm just getting it. I don't have my own experience. I'm just getting it this week. 2 pieces. We have candidates for the procedure, so this might be an option. You know, because the inflow is usually easier to find than the outflow. So the hero graft with the catheter, which you can insert even through the occluded central veins, might be an option for these cases.
Dr. Gaurav, how would you manage such a patient? And you see a lot of these issues in your practice.
So I would like to answer the first question before, whether grafts are more suitable for a certain subset of patients. I think a lot of elderly who have poor veins, our center would prefer doing an AV graft. The risk of infections is definitely higher in our centers, but if proper care is taken, in the sense you educate the dialysis technicians how to keep on rotating the site, I think graft is also a good viable option for these patients. And endovascular interventions, I believe Dr. Khanna would be able to answer this better, are easier for patients with graft compared to access, the native fistula. And I fully agree with Dr. Martin that yes, for a patient with the patient you presented, hero graft is an option, although in our country also we have very limited experience in that. There are certain centers who have been doing it, but the experience is quite limited. But temporary catheters, there are few centers who are doing transhepatic, translumbar, and down south, there are certain centers who are doing the IVC catheters also, the translumbar catheter also. But I think the hero graft is a good option for this patient.
Sure. Thank you very much, Gaurav. I think, yeah, we've kept that. I mean, we've never used Eurograft. That's something which I will discuss with our surgeons. But yeah, translumbar and IVC catheters is an option. I mean, yes, we're thinking, but again, these catheters are temporary, isn't it? I mean, we need to look for.
These are just, I would say, a bridge for transplant. Ultimately, you have to, for a young person like her, you have to look for transplant.
Absolutely. Thank you very much.
Unfortunately, these patients are so complicated. These patients are usually not the candidates for transplant, you know, rejected from many other reasons, usually full of comorbidities or unable, you know, to find the location of donor. That's the problem.
That's absolutely true. And in any dialysis unit, there would be at least 4 to 5% of patients who would behave like this, who would have difficult vascular access, not good candidates for transplant also.
Yeah, I think we've had over the years many patients in this situation, but the tricky thing with this patient is she's very young, she's only 32 now, and it's only 3 years of dialysis life, she's gone into such severe complications. And my next worry is if the transplant, the external iliac veins are occluded, so the surgeons will question where we're going to get the vein, I mean, transplant into. That's another challenge.
Can I just the last question, gentlemen, for both of you. What is your tactic for the medical treatment after this kind of procedure, so complicated, access? Do you keep this patient on anticoagulation, or you just keep going with antiplatelets or nothing?
Yes. So for my patient who has difficult vascular accesses like this and who's thrombosing multiple times, I would keep them on a small dose of acetrom or maybe warfarin, small dose. Antiplatelets generally don't help, but I've seen, although there's no literature, but this does help these patients. Acetrom 1 milligram or warfarin maybe 1 milligram. that does help these patients.
Regardless of INR, yeah? You don't even check the INR.
Yes, regardless of the eye.
Now, we use warfarin regularly in all patients who has grafts, and we maintain the INR between 2 to 2.5.
Can I ask, hi, it's Raj here from Brunei, in Singapore now. Can I ask everyone in the panel, hi, Dr. Khanna, a simple question. I saw Dr. Sudhakar Rao present beautiful cases, radial axis interventions, and he used angiogram, fluoroscopy, and panning across from the arm to the shoulder, which is very good. We always use DSA in our practice. Can I ask, some of you are very experienced in this. Is there an advantage of DSA over this angiograms? Because I'm mostly comfortable with angiograms. That's what we do for the heart. But when I started doing fistula intervention with the vascular surgeons, they taught us to do DSA, and we are sort of stuck with that habit. And then I saw all these cases, and so are we wasting radiation and time and effort in doing DSAs? And should I just be doing angiograms and just panning across one view? What's your practice, and what do you recommend?
It's a great question. It's very obvious. You have a lot of cases as well. Sometimes we are looking like crazy dancers, dancing around the patient, because as I mentioned, when you do these complex cases, I usually go with like jugular, brachial or radial, and the femoral, because I always put the stent from the femoral and trying to snare the wire, and because it's the safest as well. It's the stenting is sometimes very tricky, and if you have a wire from the brachial all the way to the femoral, then it's the safest stenting you can possibly have. So anesthetist is very often just laughing what I'm doing, because I'm dancing around the patient, doing this and that, and I'm using the angiograph because you can move the table. Sometimes you need to see the flow in the long segments, so I move the table, and this you can do only with angio. You cannot do this with DSA. So I'm combining both of these. I'm trying to stay away. It's also difficult because the radiation load is amazing in these cases, so you have to keep protecting the team, yourself, and the patient as well. So I'm trying to combine it in regard of the situation and specific patient and the location as well.
Okay, so that was good, and I think we are running late, and we have Dr. John Eichelboom, who has been a primary investigator for the COMPASS trial. He's going to be giving an oration after this, so I'll quickly end this session after my talk, and this is something unusual from the nephrology side. We work closely with our nephrologists, one of them are here, and ours being one of the largest volume renal transplant center also has a very high load of dialysis, and there are a lot of patients with a central vein catheter for dialysis, and then many of these would land up with clots related to the catheter, and some of them are really big, and they actually give us a very potentially catastrophic situation. So I'm going to be speaking on this.